Okay, good morning and good afternoon, everyone, and welcome to our monthly mastermind meeting. For those of you that are new to our meeting, we get together once a month to provide education by industry experts to help you grow and scale your business. 1 hour every month that you can focus on new ideas, hear from your colleagues and competitors about what they're doing to grow their business and increase their revenue. We have so many people on this call today, too many people to make those introductions, but I encourage you to join our Facebook mastermind group meeting, which is reserved only for billing company owners. You can post questions to the group. You can continue to connect with your entire medical billing community, because we are a community and we're so spread apart. You know, we're in Arizona today, but we have people joining us from all across the country. So just wondering if you dream about ever going on vacation and not having any worries about your staff or what's going to happen to your company if you do go on vacation. When I first got started in my billing company, I felt that I needed to be in the office every day or the work would not get done, until I discovered the concept of offshoring. Data entry and coding was happening during the nighttime, the AR was happening during the daytime, and people are being managed by a whole other team of people, and that was amazing to me. And I was really able to step away from my business and work on my business instead of in my business. So if you have thought about offshoring but are unsure about how to get started, please send me an email, get on a quick call. Happy to talk to you more about that. If you're currently using an offshore vendor and you feel disconnected from your team, lacking communication, transparency, if you see fluctuations in quality, let's get on a call and talk, and I can give you some ideas on how to improve your current relationship with your vendor. Okay, for those of you who don't know, my name is Hani Gluck. I'm the CEO and founder of 40 Global. We help medical billing companies grow and scale their business profitably by providing offshore resources in India. Today, we're going to get to our main deal of the day. We're very excited to have Tim from Practice Max with us, and was so generous with his time to come here and talk to us today about something really important. I know many of you have doctors that are always asking you, how could I make more money? How could I improve my revenue? And if they're not asking you to negotiate their contracts, they may be thinking about it. And so,
or they should be thinking.
About it. So without further ado, I'm going to introduce you to Tim, and he is going to give us some things to think about on the contracting side.
Yes, let me just make sure everybody's seeing my slides.
Okay, yes, we are.
Okay, great.
Any questions, comments, feel free to put them in the chat box. Allison and I will be monitoring that throughout the entire thing. So if you can't hear us or any questions you want to ask, please.
Well, hello everyone. Thank you for being here. Hopefully we'll have some information that'll be of benefit to you. I've got a limited amount of time, I believe about 45 minutes, and then we can do some Q&A afterwards. And I have packed slides with lots of details, so I'm going to go quickly. Please hold your questions, but as we're going, as you have questions, maybe write them down so that when we get to the Q&A section, or you can do the chat and let Hani know. And then, you know, we can pick them up at the end so that we keep through the content and try and get as much in as we can in the 45 minutes. I've got about 32 years of experience in healthcare revenue cycle management. And for the last 10 years of those, I've focused heavily in payer negotiations. I've literally negotiated hundreds of contracts with payers throughout the country for multiple specialties. So I've got a breadth and depth of experience, but I'm always learning too. So that's one of the great things about this industry. Things don't change, they don't get better unless you do something to change them. It just doesn't happen overnight. And practices are struggling financially, yet many of them fail to negotiate their contracts or to renegotiate them. They may have contracts that are 10 years old and they haven't renegotiated them, which is just critical to their business. But why think about contract management as a revenue generator for RCM companies, probably two primary key reasons. If you increase the revenue that the client gets, many of you are on percentage-based billing systems with or contracts with your clients. So if they increase their revenue, you can increase your own revenue. But it also can be a fee for service that you provide, a service that you provide to them, and capture a fee for that service as well. There are secondary benefits, such as it improves customer satisfaction. When they're getting more money, they're happier. It also helps them to be insulated in negotiations. So if they're doing it themselves and they can turn it over to you where you can insulate them, then they're not going to get put on the spot by payers to make decisions that may not be advantageous. Contracting is, to me, more than just renegotiating or negotiating the rate. It's looking at the contract language, it's maintaining contract documents. By the way, I may not review everything you see on the slides. I'll just talk extemporaneously, but it's there for you for food for thought. So if I don't cover everything there as we go, it's just there for you. But it's about change or notice management, compliance, rate negotiation and renegotiation obviously is one of the keys. Also, though, payer contracting is really a combination of art and science. In terms of science, you want to do great analytics, you want to do your due diligence, have the information there, but also understanding when to push harder, when to back off, when to escalate, things like that are critical. So that's part of the art of payer contracting. Some of you will say, well, gosh, I don't know anything about it. I've never done it. So how do I do language review? Well, one of the things that has always been an advantage for revenue cycle management companies over practices is that we get to do business with lots of practices, and they do business with lots of insurance companies. So you probably have at your fingertips or available to you many contracts. Just review those contracts, and you'll begin to see things that are in one contract but not in others. And so you'll start to know what the weird things are, what are your common, and then you can use that in your negotiations with the payer. When they throw out something that you don't see in other contracts, you can say, well, what's this about? So it gives you an opportunity to learn from your existing clients in their contracts in order to help you get started. And then you'll have experience as you go in this process. With regard to language, look at termination languages, and I'm just going to talk about a few key things. But look at termination language. Sometimes you'll see contracts that have a 180-day termination time frame, and that's probably too long. You may need to have a provider who needs to get out sooner for one reason or another, and so you just want to kind of look at the time frames for your terminations. And sometimes 30 days might be too short, so you want to figure out that middle ground and negotiate that. More importantly, many times the terminations are tied to the renewal date. So if your contract renews January 31st or February 1st of each year, and here it's March, and you want to do a termination, but you can't do it until the renewal date, you're stuck with almost a year. So you want to make sure that terminations are not tied to renewals. Believe it or not, there are contracts that have penalties if you terminate in order to renegotiate rate. So make sure those penalties are removed. Make sure that any of the provisions for immediate termination are acceptable to you. The payers will have different consequences for immediate or reasons for immediate termination, and you just want to make sure that those are viable for you. Obviously, rate is something you want to look at. Make sure that the rate in the contract is actually what you negotiated. I can't tell you how many times the contract says something different than we negotiated, including escalator clauses. Can they reduce the rate without consent or objection? You want to look for that and make sure that they can't, that your provider, when they get a notice of a reduction, has an opportunity, or they can terminate. Look to make sure mid-level rates are not excessively reduced. Typically in the industry, you'll see a 15%, that's a Medicare standard, but you don't want to see 20 or 25% with other payers. Product lines, make sure that you're getting all the product lines with that contract that you want for the practice. Sometimes the insurance company may have 10 different product lines and you're only getting 2 with the contract where you wanted more. Or maybe you're getting Medicaid and you don't want Medicaid, things like that. So just look at product lines. Make sure that you're going to be able to be compliant with the contract by reviewing its insurance expectations and that the practice is consistent with those. M&A language is critical to look at. So M&A standing for merger and acquisition. You want to have language in there that if your provider's practice is merging with another, is acquired by another, or is acquiring another, that the rates for your contract may apply. Make sure that the insurance company doesn't get to decide which rates. If you get two merging, they both have contracts, many of the languages will say they get to decide whose rates carry forward. So make sure that that language is out of there if you can. Make sure that the contract is reasonably assignable. And in many cases, they'll provide that they can assign their contracts, but they don't allow the practice to assign theirs without approval. Well, at least make sure the language gives that reasonable approval. It won't be withheld without unreasonably. Rates determined by the insurance, we want to make sure that they can't do that. Also with notices or changes, find out how the notice is sent and make sure that it's certain. So a lot of times they'll say they can give notice by putting it on their website or something. And so you're getting changes to contracts and you can't tell that it's been done because you didn't happen to see that on the website. Make sure that those change notices have to be sent by a certified or a receipt at least, so you can prove that it was delivered and received. Make sure you understand the amendment methods for the contracts so that they can't just amend arbitrarily or without notice and so forth. Also, as you review the contract, look at all the language because many things will be in odd places. They will be under headers that say one thing, but really it's talking about something different. So make sure you review all the language and be picky about everything you see. You may see little things that are not substantive to you and you don't care about them, but at least then you can give those up in order to get the things that are important to you. Documents and notices, part of contracting is just maintaining all the documents. The contract copy, make sure that you get a countersigned copy back. Otherwise, you may not have an enforceable agreement. Very often, you'll have the provider sign it, send it in, and then it doesn't come back with their signature, so it's hard to enforce it. Notice management, make sure that the payer notices are being received and that you're aware of them and what they're telling you. So if they're terminating, if they're changing rate, if they're changing product lines, many of the contracts provide that they can just remove a product line without terminating the whole agreement. So make sure you're getting these notices and you're aware of those changes. Otherwise, providers are very unhappy when they're scheduling patients and all of a sudden they're not getting paid because they weren't aware of a product line going away, or there's a need for credentialing or whatever. Compliance. Part of contracting in my mind is making sure that you're remaining compliant both on the provider side as well as on the insurance company side. So make sure that you know what the rates are supposed to be and that when they're paying according to those rates. There have been lots of studies. MGMA has done a handful of them. And from those different studies, you'll find that anywhere from 4 to 12% is lost by practices that don't make sure the payers are paying according to the contract. So you got to know what those rates are, make sure that you're getting those payments, and then fight when you're not. Also, though, a lot of times you'll have an escalator built into a contract that means after a year or 2 years, the rate goes up to something new, and many times the payers don't implement those. So that's part of compliance to make sure that they're paying properly. Also, part of compliance is know what things you're supposed to notify the payer on, and make sure you get those notices out to them. So if the insurance changes, if a provider leaves, if there's been an acquisition, you have obligations to notify them and make sure you're doing those things as part of your compliance efforts. And then, of course, we've talked about rate negotiation, and renegotiating is certainly part of the contracting process. Believe it or not, payers lie. They do it very frequently. They'll say, hey, we don't have room to negotiate now. There's not in the budget. We don't pay anyone what you're asking. And we know from experience that we maybe did the negotiation for the practice next door and they do pay more, but they'll tell you they don't. So make sure that you don't just buy into their arguments. Why do you think that they say no to reasonable requests? So for example, maybe you're only asking for 2% increase. Consumer price index in your particular area shows that that's how much you've lost to inflation. That's all you're asking for, and it's reasonable. So why do they say no? Simply put, because they can and because people will accept that. Most people, in fact, when they come back and say, no, we can't give it to you, go away. So you may have to go back to them repeatedly to get past a no and actually make progress. How do you do that? We'll talk about that as a question at the end. So what are some of the additional challenges for you as an RCM in doing contract negotiations? Well, maybe you don't know what to look for. Maybe you don't have data that can help you. Maybe you don't understand strategies to employ. So we'll talk about a handful of those things going forward here. For example, talking about data sources. Data is incredibly important in the negotiation process. And so you've got to know where to find data. Consumer price index is a very common one. It's a federal government statistic that helps you identify how much the cost of doing business has gone up. And there is a consumer price index data source for medical services. And it's broken down by region. So you'll want to know that information so that when you go to a payer and they offer you 0.5% or no increase or 1%, yet you can show that the 5-year average for CPI in your area is 2.8% or 3.2% or whatever it is, then you can support why you need that increase. Fair Health puts out data on what practices are charging. That data, you can acquire it direct from Fair Health, or you can go to Optum, or you can go to other resellers. But having that data is very important. Notice I said charge information, not allowed information. That's also important in the contracting process because you may negotiate percent of billed contracts. So you have to know that your fee schedule is reasonable and be able to support that when the payer says, hey, I can't give you that percent of billed because your fee schedule is way out of whack. So using that Fair Health data will help you to support what you're negotiating. Also use the individual client's information in the negotiation. I'll give an illustration of that later as well. Overall client information. So you may have more than one client, they may be of the same specialty, and so you'll know what they're paying from practice to practice to practice, so you can use that information to know what you should be seeking for the client you're currently negotiating. Associations will put out data that you can use about contract rates. You can go to CMS for information, use their information on payment reform, and then market intelligence. We'll talk a little more about each of these things. So the Bureau of Labor Statistics is the one that puts out the CPI information. Here's just an example of one of the screens on their website that you would go to start drilling into the information that you need. You'll pull back information from them that might look like this. I've picked a particular region for medical services and just pulled some historic data. So it tells you the rate of consumer price index change. These are percentages month by month, year over year, and it gives you the annual averages. And then you can calculate, what your 5-year average is or 10-year average or whatever numbers are beneficial to you for your negotiation. Also, though, many contracts will have been executed 2 years ago, 5 years ago, 10 years ago, or even more, and never renegotiated. So you need to figure out, well, what is the value of that contract in today's dollars? And so you'll want to break that down. And so you can use something like this, where you pick the year that the contract was implemented, plug in the value of that contract, and then it'll calculate out what it should look like in the current year. So here I've just given one example. So when you're doing negotiating, you want to break the data down. Most of the times they're talking about a fee-for-service schedule that's got thousands of procedure codes and a whole bunch of different rates, and it's hard to know what that means to a practice. So you want to do good analytics to take that and quantify that into an easily identifiable number to compare from plan to plan to plan for that practice. The way you do that is you look at all of the codes being billed, how frequently they're billed, multiply out the value based on the contract for each code based on times that frequency, and then divide that by the number of visits as an example, and now you have an average per visit allowance. So this illustration here is using that. So in this particular example, the practice had, based on the contract when it was negotiated, a $400 per case or per encounter value, and it never changed over time. And so this shows what the current 2019 value would have to be to have the same value. That would be $536, which is a 34% increase. So you have a big task now to go back to the payer and try and bring that contract from where it was up to where it needs to be today just to maintain value. But you can use tools like that to do that. We talked about the charge data already, but also let's talk about allowed data. There really aren't any good sources for allowed data, but Fair Health does publish some allowed data. Allowed meaning different than the charge. So you charge $100 for a procedure, but the insurance company allows $80. So that contract allowed is what you're looking at. And so if you're negotiating for $200 instead of the $100 or $80, and they come back and say, well, gosh, nobody's getting paid that, how do you refute that? Well, you may need to have data, and so it's very difficult. But you could potentially use the Fair Health data. Just remember that their data isn't pure. When it comes to allowance, it is derived. They do a mathematical equation to come up with it, and it isn't pure like their charge data. You could use the bundle payments for care initiative information from CMS to capture data that you can use in your negotiations. If you have a new practice provider coming into the practice, he may know what the practice, he might have even been involved in negotiations for another practice and may know what somebody else has got. So this is where the practice starts getting its own market intelligence by looking at, a provider can't treat its own family member and get paid for it. So maybe those family members are going to another provider. Maybe you get an EOB that shows what that provider is being paid. So you use different kinds of practice intelligence to help your negotiations as well. You may create a grid that shows where each of the contracts for a particular provider is and where you're at in the negotiations, and use that information to help you negotiate. So if you look at the far right, you see one plan's at $760, or a couple of plans are up in the high 400s or low 500s, yet I've got other plans down around 200. Now I know that those low plans aren't market worthy, and I can use this data for my negotiation. Some of the association data, here's a table that we got from one of the associations that shows what anesthesia rates are in various regions. So we can use this information to know if they've offered us something market worthy or not. You'll want to do some analytics. This is just an example of a spreadsheet that we use. You can have very simple ones, you can have much more complex ones, but this helps us to establish an understanding of what that fee-for-service schedule that they offer actually means. Even sophisticated practices, how am I doing on time, by the way? Okay, good. So even sophisticated practices make mistakes. It's funny, we've looked at national practices that have offices all over the country, and we look at contracts and we see things that we believe they did wrong. So whether you don't know anything about this or whether you're sophisticated, there's things to watch out for. Many of them, believe it or not, fail to negotiate their rates, and most of them fail to renegotiate those rates. So they just accept what the payer offers, and then they're stuck with that forevermore. Many of them lack annual escalators. The reason you want to, there's multiple reasons for annual escalators, but one of them is the contract renegotiation process is long, arduous, and painful, and people don't like to go through it. So very often, when a rate's been in place for a year, they know they should go back and renegotiate, but they really don't do it timely. And so the practice loses ground to increased costs of doing business, and they're no longer market worthy. So if you build in an escalator, so you've got a new rate starting April 1st, then next year on April 1st, that rate increases by some factor. And then maybe the next year it increases. Be careful about how far you go out, because if you go out 5 years, and let's say you've used the 5-year average CPI adjustment, so each of those 5 years you got 2.8% increase. Well, if inflation is now 6 or 7 or 8%, you've now harmed the practice over time. So you want to have some escalators, but you also want to be careful about how far out you go with those. Very often they don't assess the rates being offered very effectively. So you want to be careful about your analytics. You know, you don't want to just say, well, okay, they're giving me 100% of their fee schedule. You want to weight that against the procedures that your practice is using, how frequently those procedures are being done. Sometimes a practice will look at, let's say they look at the E&M codes, they look at the rate and they say to themselves, well, gosh, that's 12% greater than I've been getting. This is a good offer. They accept it, but they didn't weight all the other procedures, and because those were so much lower, their net effect was either a loss or a very small increase. For a practice in Chicago recently, in New York, we negotiated. They thought they had an offer that was an increase and a very good increase. And when we did the spreadsheet and analyzed the outcome, it was a loss. And so you got to be very careful about those things. Very commonly, the payer will say, well, we don't give out our fee schedule, or give us your top 20 codes and we'll give you those rates. Well, that might work if your practice only bills 10 codes. But if your practice is common and they bill 100 codes, you've got to have the rate for all the codes that they bill. Very often you can ask for the fee schedule and they'll give it to you. But if they won't, give them a listing of all your codes and make sure you get the reimbursement. If your practice is using modifiers, make sure you give them the codes with the modifiers so you get the right rate that you're analyzing. But never just accept top 20 or top 25 or 10 or whatever. Do the due diligence. Many practices accept what payers say. If a payer says, hey, I don't have a budget for an increase, oh, okay, well, thank you. They lie. Or maybe they don't actually have a budget, but that doesn't mean they can't still negotiate an increase. So don't accept what they tell you. As you do more and more negotiating, you'll find more examples of why you shouldn't, because they lie. Many practices fail to accentuate their own value proposition with the payer. So the payer comes back and says, well, I don't see any reason we should be paying you more than the guy next door. And very often there are legitimate reasons why they should be. So you need to understand those things and use them. Again, we talked about how practices lose money by just not knowing what the contract requires the payment to be and ensuring that that's what the practice is actually getting. And I can't tell you how many practices don't do that piece. Maybe their software makes it difficult or doesn't have a provision for it. You've got to find ways to make sure that you're handling that. Strategic positioning is critical to negotiations, and many practices don't position themselves before they enter into the negotiation. So they're stuck with their baggage that they didn't correct. Many of them will ignore their own fee schedule correlation to their contract, which is a critical error. Oftentimes they've set their fee schedule at a rate that is lower than the contract would allow. The vast majority of contracts out there say that the payment will be X or Y, whichever is less. X is usually the contract specified amount. Maybe it's a percent of Medicare, maybe it's a percent of their schedule, or your billed amount, whichever is less. And if your billed amount isn't high enough, then you're going to lose money. So that's part of the reason for using that Fair Health data for charge data to make sure you've got that high enough. But even then, compare that against all the contracts that you have to make sure it's going to be high enough that you're going to capture the maximum allowable under each contract. Oftentimes there's disadvantageous language in the contracts, and many of them just accept the language thinking that they can't do anything about it. Well, sometimes you can't, but very often you can. So you need to review those and negotiate that as well. One of the important things is to track the year-over-year change in the payer's schedule. So for example, United Healthcare or Aetna or several payers have their own standard fee schedule. And if you contract for that fee schedule, and next year maybe you build in an escalator, you're smart, you know that you want to keep up with inflation, so you build in a 3% escalator. So now next year, instead of 100%, you're getting 103%. If they have adjusted that schedule downwards by 5%, you have a net effect of a minus 2%. So make sure that you're tracking their fee schedule year over year to see how it's changing. I can't tell you how many times I've negotiated with a payer and they say, well, we don't increase the percent of our schedule because we just adjust our schedule year over year. And then you go back and you look at it, and yes, they adjust their schedule, but it didn't adjust on the codes that practice used at all. So the practice got no increase, or maybe it went down, or maybe it went up, but it was only 0.5% or 1% when inflation was a higher percentage. Or you haven't negotiated that contract in 10 years, and so now you need 30%, and it may have changed by even 2 or 3%, but you're nowhere near to the current market value that you need to be at. So make sure you're tracking their schedules and how they change year over year. All right, so you say to me, well, gosh, I don't know anything about strategies. So let's talk about a handful of different strategies that you can use. And I'm going to be fast and vague. We can get into more details as you have questions at the end if you do. Remember, in negotiating, a golden rule. In real estate, it's location, location, location. In contracting, it's he who speaks first loses. So what do I mean by that? Well, oftentimes you'll approach a payer, you'll say, I need an increase. And the payer will say, well, what do you want? What are you asking for? Well, if you come out and you think to yourself, gosh, I don't think they're going to give me 5% or 10%, I'll ask for 2%. If they were going to be willing to give you 4%, you just lost 2%. So since you don't know what they'll do, the best thing to do is to try and get them to speak first. Now, in some cases, they're crafty. They know that same rule, so they're going to make you put out the first offer. In that case, you're saying, well, gosh, I'm going to lose, right? No, but be conscious of the rule and the reason for the rule, and then realize that, okay, if I'm going to have to speak first, I may have to put out a much higher number so that I know I haven't left any dollars on the table. When you do that, you have to be a little bit careful, because if you come out too high, they're going to get indignant. They're going to say, gosh, you're not being realistic. They're going to use those things to shut you down. So you do have to be somewhat realistic, but you go out for a high number expecting to get a no. Okay. Set reasonable expectations with your clients. If they think you're going to get 30%, you might be able to, but odds are you're not going to be able to. So be sure you're setting reasonable expectations with them and with yourself as you go into the negotiation. As I said a few times, payers lie. I think it's critical to have credibility in negotiations, and lying will always harm that. So don't lie, and don't tell them, well, gosh, you're only offering me X, and I've got 3 other payers that pay me Y. If those 3 other payers aren't paying you Y and you lie, that is going to burn you. You say, well, how's that going to burn me? How do they know? Payers have market intelligence just like we do. Some of the market intelligence they gain is just through secondary claims. So when you send a secondary claim to a payer, that tells them what the primary payer allowed. They build that data so they know what you're getting paid by other payers. If you lied about that, they know you lied, and you've lost credibility, and they're not going to take you seriously. Don't get hung up in how to get there either. Sometimes I'll have a practice that says, I have got to have this price for this procedure, and the payer's schedule is half that. I don't care if I get that price if I make it up on all the other procedures. So be flexible. Look at using carve-outs where they're helpful for you, but look at overall percentage of increase if that can get you there where the carve-outs won't. Sometimes carve-outs can be hazardous to you. So what I mean by carve-out is, okay, you've got a fee schedule of 100 codes that you're billing, but you've got one or two, and maybe they're offering you 100% of Medicare for that, or 125 or 200 or whatever your specialty is and whatever the proper amount is for that specialty, they're offering you that rate. So if it's 200% of Medicare across that schedule, you're saying, okay, that's pretty good, but I really need 300 for this one code. Sometimes that's a disadvantage because they might not give you the 200 overall, they might give you 180 or something else overall, and they'll move the carve-out code way up. And you think, okay, I've won. Then tomorrow, the practice stops doing that procedure code, and now you're back to 180. So you have to balance whether you're going to use carve-outs or not in your negotiations. But don't get hung up on how to get there. There's lots of ways to get there in the end, and just be flexible. Sometimes payers you're negotiating for a particular payer, and they say, well, why don't we do a case rate versus a fee for service? If you do the math and compare it out, and that makes sense, feel free to do that. Sometimes I've had payers say they want to go from a case rate to a fee for service schedule, and they think that's going to trip the practice up. But if you're doing the due diligence on your analytics, you'll be able to know what those both mean, and you'll know whether you've got to move up or not. Don't ever stop until you get a no. A no is what you're looking for. People think that's something to be afraid of. It's not. And what do I mean by that? In a payer negotiation, well, let me put it this way. I had somebody who came and interviewed to be a negotiator on my credentialing or contracting team. In the interview, I asked him to give me an example of where he's had success in negotiations. So he talked about a payer and he talked about what he got. And I asked him, well, how do you know that you had success in that case? He said, because we got what we asked for. Well, he didn't understand. We asked him a couple of questions about that, and he didn't understand why we thought that was bad. But we thought that was bad because he may have not asked for a high enough amount, and he may have left money on the table. If he hasn't gotten a no, he doesn't know if he left money on the table.
Go for the no.
Yep, it's critical. But know that when they say no, they might not mean it. So you have to test that more than once, many times. We've had negotiations where they've said no 5 times, and then we got the increase. So be sure to test it. But it is important to get a no.
How did you change your strategy when you got the no? Like they said no, you just continue to ask?
Yeah, it depends on the circumstances. It might be giving them more data. It might be getting them to tell you why they said no. And in what they tell you back, you see your path to make, well, that's not really true. So now all of a sudden, there's no reason for the no. So there's lots of ways to do that. It's just being flexible. Payer fee schedules. If a payer says, we're going to give you 100% of our fee schedule, is that a good rate? Maybe. Is that the top? You may think it is. It's 100%. How can I get more? But very often, payers will pay multiples of their fee schedule. I've had payers who've paid as high as 595% of their own schedule. Now, that's the extreme. That's not the norm. But it is possible to go above that 100%. So you got to know that, and you got to test it. Analytics, compare all the rates, but not just comparing the rates, weight them. Because if you don't weight them, you may have some that are very high with low utilization and others that are very low with high utilization, and your net effect is bad. So you have to weight it. Always simplify it as well if you can. So instead of having 100 codes and the rates and you're trying to figure out what all that means, try and break it down into an average per case wherever you can. Remember to use the psychology of negotiating when you're dealing with payers. So, for example, I never want to seem arbitrary. Rarely do I request a number that is just a flat number. I usually 0.7 or 0.9 or something that makes it seem like we really put our pencil sharpened it, and we really got down to what we wanted, because they're less likely to push back when they have that sense from you that you really know what you need to have, and you've gone as far as you can. You haven't just been arbitrary. Also, psychologists will tell you that you need to provide the reasons for things that you ask for or request or say no to. But it's funny that you don't have to provide a good reason. It's amazing how many times, if you have any kind of reason whatsoever, it may not even make sense, they will accept it. Now, obviously, you want your reasons to be as well-reasoned as possible, but sometimes if you don't have a well-reasoned one and they ask you why, just give them a poorly reasoned one and it'll go by. That's a hard thing for me to do because I'm kind of a perfectionist, but you have to do that sometimes in negotiations in order to get past the issue. Escalation is a tool that you have to use, and that comes from two different perspectives. Remember that when you're dealing with provider reps or contracting reps, they are given fairly narrow parameters in which they can operate. So if you're negotiating a rate and they say, I just can't approve that, then you may have to go to their supervisor. You may have to ask them to set up a call with them. You don't want to alienate them. So set up a call with them and their supervisor to see what we can do. Because their parameters, same thing with not only just with rate, with contract language as well. You may have to set up a call with their quote unquote legal, which may turn out just to be their supervisor. But you may have to escalate to somebody else who's got more discretion authority. But also when it comes to escalations, talking about rates, in that example where we saw that we had a 34% need to get back to the same market value, most payers are very frequently going to tell you, I can't give you a 34% increase. So one of your tools to get there is, well, let's break that down, that big elephant, into bites. So I might have to get 15% one year, 8% the next, and then a smaller percentage the next to get to that 34. So you may have to do some escalators and break it out that way. But even if you're at a market-worthy rate, then your escalators are going to be based on just the rate of change in cost of doing business. So you'll want escalators for those reasons. Other contract strategies to consider: termination. Very often, payers will say no, and they'll say no, and they'll say no because they don't think you're serious. So you may have to be willing to put a termination on the table. That's often a difficult discussion with the practice because the practice will say, hey, I can't terminate. But if they don't give you that tool in your toolkit, then the payers aren't going to take that negotiation seriously. So what do you do to bridge those two gaps? Well, you might say to the doctor, most of the time, we'll get an increase if you've got experience and you know that. Sometimes we won't. And so if we've put a termination on the table and we get to a certain point and we aren't getting the increase, we can rescind our termination. That's a little risky, so you have to explain the pros and cons to the provider, because every once in a while, incredibly rarely, the payer will accept the termination even if you try to rescind it. But I can't tell you how rare that is. So if you put it on the table and they think you're serious, and now you're close to the termination date and they're going to wait and see if you blink, in some cases you may have to rescind it. In other cases, you may go ahead and just let it go forward. Once the termination goes in place, then they come back to the table and negotiate. So you're going to use different tricks like that, but very often you've got to be willing to at least put it on the table. Know your state's regulations, though, because in some states, the payers are required to notify their membership when somebody's going out of network. So if you put a termination notice on the table, maybe it's for 120 days, and they have to notify their members 30 days before termination, you have to keep that in mind so that when you get to day 40, if you haven't made the appropriate progress and you're not willing to move forward with the termination, that you actually rescind it before they have to do their notices. So be conscious of those kinds of things. Know the client's value proposition. I've just listed a handful of things. There's a number of other ones, but these will give you some ideas of things that you want to sell to the payer as to why they want to pay your provider more and keep them in network. Maybe it's a top doc who's been, written up as a top doc. Maybe they have extended hours for convenience for their members. Maybe they are the only anesthesia provider for a certain hospital or a certain ASC. Maybe they are the only rheumatologist in the whole town, or whatever it is. Know their exclusivity items. Know if they have unique training. Maybe they're doing a procedure that nobody else is doing, or it's very new, and the value of that procedure is better outcome for their members. It saves them money because they don't have to do repeats or this or that. So know about the unique things that your providers are doing. You also want to track your providers' satisfaction scores and make sure that you're providing that information. If they're getting very high satisfaction scores in their surveys, you provide that back to the payer, because they want to know their members want to go to good providers. They don't want to get complaints back, and so that's a value that you can sell. Referral relationships. Maybe they're a specialist and they've got referral sources that have clout with the payer that definitely want to keep referring to you and will be willing to go to bat for you. Write a letter that you can use with the payer. So you got to know those referral relationships. Make sure you're keeping track of quality scores, the MIPS and the HEDIS and whatever else is out there, so that you can use those statistics. And that's part of positioning also. If those scores aren't great, work to improve them, then use that data. One of the things that we have success at a very high level with practices, because we are not afraid to ask for the moon. We're not afraid to have a payer laugh at us and say, that's just ridiculous, because often we can support that it's not. But even if it is, we want to start high. And it is amazing how many times we'll achieve something that nobody thought we could. And we go into it not even thinking we can. But we do, because we're willing to shoot for the moon. So you can't be afraid to do that. All right, so let's talk about positioning, for example. We do something that we call leapfrogging. And I've just got one example here talking about networks. And so we'll talk about networks for a few minutes in lots of different perspectives. One, I don't know how many of you here have gone to MJMA's financial management and payer contracting sessions, but in many of those, you'll find people who say networks are horrible, stay away from networks, avoid them like the plague, and they talk about all the problems that networks create. And I agree that there are certain problems with dealing with networks, but I would, well, I'm sorry, say again.
Clarify the networks. What kind of networks?
Oh, the national networks like MultiPlan or Three Rivers or Zealous or Galaxy or ACPN, or there's lots of them around. Okay. But many of them do not have near the negotiating clout that a Cigna or a Blues that has a much higher membership that they bring to the table. So you can get higher rates with them. So remember that slide where we showed all the different rates. I may purposely go out and negotiate with some networks where I get a higher rate. So now when I'm talking to the payer, I can say, well, you're not paying a market-worthy rate. Sometimes the payer will say, well, yes, we are. And I'll take that grid that I created that is de-identified. So in the one I showed on the slides, it showed plan 1, plan 2. So we took away all the names and all. So I'm not giving away anything I can't tell. But I'm just saying, here's our contracts. You fall in the bottom third. Now, because I positioned to have payers up higher, now I've got something to use as a negotiation tool. And so then when you negotiate the next rate, you get them up above the others, so that you have to kind of leapfrog each of them as you renegotiate, so that you're always pushing them to be market worthy. So that's kind of what I mean by leapfrogging. Positioning, of course, new techniques is a good way of positioning, because they often have better outcomes for members, save money for the plans, things like that. Also, you want to think about positioning from another perspective. You don't want to get positioned negatively. So for example, let's say I'm negotiating for a hospital-based practice, and I'm negotiating, just make up a plan with the Blues, and I'm pushing hard. I want them to give me more than they're willing to give. They may come back to the hospital and say to the hospital, gosh, I think we're going to lose this group. They're just not being realistic. The hospital will come back to you then and say, what are you doing? You have to be in network with them. And you very likely, they will have conveyed to the Blues, oh, well, we'll talk to them. And you just lost clout. You lost strength. But if you know you're going to the Blues and you're negotiating, and you're going to have to negotiate a high increase, and it's going to be a painful discussion, why not go to the hospital ahead of time and say, hey, look, we have to increase our rates. We have to be economically feasible, financially responsible. We have to increase our rates with the payers. They haven't kept pace in quite a long time, and you can give them some details, just not all details. But you prepare them to know that you're going to the Blues, and then you tell them, we are absolutely not being unrealistic. We're not going to be unreasonable, and we will make sure that we stay in network. But we need you to be aware of this and not to react negatively if the payer tries to position against us. So you want to think about positioning from all kinds of different perspectives. Also, you want to recognize the things that save dollars for the plan. Because in a negotiation, you want to find mutual value. You want them to want to contract and to be willing to pay you more. So find the things that save them dollars so that they can afford to pay you more in the other areas.
Less hospitalization.
Yes, less hospitalization is a good example. It could be any number of things. Maybe you're sending to a physical therapy group, and you're making sure that when you do your services and then you send out to another group, you're sending to the more economical group, which saves them money. All kinds of ways that you can look at that kind of thing. So creating mutual value is very important. So find out. It's a critical mistake in negotiating to assume the other side's position or what they want or need or what they think. Find out. Ask. We were doing a negotiation for an urgent care, and we were seeking a high rate. And in that urgent care, they didn't want to pay it. But we said, well, why not? They said, well, you're not being competitive or this or that. And through the discussion, it turned out that they really needed an urgent care in a particular location. And if they had one there, they'd be willing to pay more. So find out what they need. Think about value concepts as well. All right, we're going to skip. Remember that this is a regulated industry, so you can't divulge information about various contracts to different payers or different providers. So skip through that. This slide just gives you some examples of different successes we've had. So you can have very high percent increases. The norms are not typically that high, but it is very definitely possible to have these kinds of increases. And these are just a handful of different examples. On average, we used to not do the contracting for a bunch of our clients. Then we started doing the contracting for them. So we were able to track how much gain they captured, how much gain we capture. And we found that on average, we captured 16% more than they were doing. Here's some resources for you. Here's a good book on negotiating. It's called Negotiation Genius. You can also go to the financial conference for MGMA. Feel free to follow up with me as well.
There's also another book. Another book is Never Split the Difference.
There's actually a ton of books out there.
Yeah, so many on negotiations, but that's a good one, really.
So let's just open it up to questions and answers.
Okay, awesome. Well, Tim, what I love about this topic is that you can make more money as a billing company owner by just doing this one thing.
That's correct.
Right? How brilliant. You don't have to get one more client and you can just make more money. So that's what I love about it. But I have a couple of questions, and we have some questions coming in. I want to speak about how would you, if you're a small billing company owner and you're not the size of Practice Max and you don't have like a huge department to do this, what advice do you have for that smaller size company if they want to do something? What would be like a first step or something they can do?
Well, so on one of the slides, we showed a number of different contracts, and we just laid out what those reimbursements were. So they can just take a client, lay out that information themselves, and since they don't have a lot of resources, they don't have to do it overnight. They can take a couple of weeks or a month, however long it takes to gather the contracts, to review them, to analyze them, to create that grid, and then just target the one that is the lowest, that's way out of whack from all the rest. And then and maybe if you look at that and you find that, well, not only is it the lowest, but it hasn't had an increase in 5 or 10 years. Now I'm just targeting one thing. I don't have to do them all at once. A lot of times in negotiations, doing them all at once is advantageous because you can't create that leapfrogging effect that you need to be able to bounce above the others. So just pick one, and just usually you pick the low one, because the likelihood of success when they're that low is much greater. So they can have success there, and every success they have puts money in their pocket. So don't be afraid to start just with one at a time.
Are there certain carriers that are easier? Like, could you give us some clue as to like who to start with?
Networks are easier.
Okay.
So you'll want to be conscious of some of the problems with networks. So, for example, if you have a practice that you contract with 5 different networks, payers don't pay the same. So now all of a sudden you've got networks with one's paying you 75% of bill, one's paying on their own fee schedule, another one's paying over here. Now it becomes an administrative challenge for your staff. So overcome that. The way you overcome that is negotiate all of them to be about the same, so that your staff knows that they're all 75%. So if I get something that's 85%, it's 65%, oh, they did it wrong. It's easy now. So you overcome some of the challenges with the networks, but get several networks so that they're easier because they don't have the negotiating clout. They want the volume. And now you also have created an impression on rates that you can use for leapfrogging. So it gives you 2 advantages. They're just easier because they don't have the negotiating clout that the other payers, the commercial payers, have.
And who would we reach out to? Like, who is the best person? Is it the local area rep? Is it, like, when you're making that call, who are you asking to speak to?
Well, I don't use local area reps anymore because we've built a team, we've built a rapport, and we've now can go to a person who's kind of dedicated to us for those negotiations. But when you're small and you haven't done that, just like I had to, you go to the rep that's local. You just reach out to the plan. Very often, if you ask your client, they'll tell you, oh, I got this offer faxed over to me. You can use that as a starting place. Those payers will fax even after you get a contract in place. They'll fax your client. So make sure when you negotiate a rate with a network, let's say it's multi-plan, and you got a high percent of build. Maybe it's 90%, 95% of build. Make sure your client knows that you've got that. And make sure your client tells you if they get any other request from that payer, because what multi-plan will do is they'll send them an offer at 75, hoping they bite and just sign it, and now they went from 95 down to 75.
Okay, so that's a good point. When you get those letters, because I've seen, we see them all the time, right? And specifically from multi-plan and those groups, what is your recommendation? How high above the offer should you go?
Well, it's going to depend on the client and a number of different factors. But I'm going to shoot for the moon.
Right. So give me the moon. What is that?
The way networks work, the way they make their money is they get a percentage of the savings to the plan. So if the negotiated rate is, I'll use an extreme to illustrate, it's 50%. There's 50% savings then, and they get a percentage of that. So they have to have a discount. So going in that they're going to have some kind of percentage. They're not going to pay you 100%. So maybe I ask for 98%, okay. 97.
Great.
And they come back and say that's ridiculous.
Okay. Oh, wow. Okay. Let's get to our questions because I have many, but you guys have more. So Ramesh wants to know, am I correct in understanding that negotiation is based on specialty? It is more difficult to negotiate for some specialties, such as internal medicine. What are some techniques we can use to get payers to be willing to negotiate with us, especially in a smaller practice? So I feel like we talked a little bit about that.
I think so. So you want to focus on many of the things that we talked about as techniques. You're absolutely right. if I have a 200 physician emergency practice, filling an emergency department or departments for a hospital group, it's easier to negotiate. That one that had 595% of the payer schedule was for an ED group. Certainly easier to negotiate for them than a solo family practitioner, internal medicine, and so forth. But at least use something like consumer price index, because that illustrates a fair and reasonable basis for an ongoing annual increase.
Okay. Let's go to the next one, Joshua. So Joshua wants to know, how do you charge the client for the service per hour, per payer? And that was also a question on my list. So Josh, I'm glad you asked that question.
Well, and the answer is all the above. But depending on your relationship with them, what the value to you is. So if it's a very small practice, spending the time and effort to negotiate may not return the value in terms of their increase and your percentage of that increase. If it's a 200 doc ED group, chances are you're going to get the value just in increasing their rates. So you might not even have to do it on a fee-for-service basis. If you do it fee-for-service, then again, you can do all the above. So you could do so much per contract, but I tend to do them based on the work involved. And no two negotiations are the same. So I don't know what the work's going to be on the front side. So I use a measure of the work being hourly. So I'll just set my rates at so much per hour. Now I can get higher rates than somebody who's less experienced, but you just start somewhere. And maybe you've already got a consulting rate with the practice that you apply to your contracting efforts.
Okay, that's great, because then you definitely cover yourself with your people. Okay, thank you, Joshua. That was a good question. Okay, so Kevin wants to know the same thing, how you're charging to the contracting, you're charging extra or included in the fees, and do you employ an attorney?
We do have a staff attorney that we use, but we've had attorneys come to us. We've talked to them about joining our team. We've had more than one join our team, and there's a lot of training because it's a little different than what they're trained in.
Yeah.
So you end up teaching them, but we do currently have an attorney on our team, and she helps us with some of the reviews. I'll tell you though that when I review a contract, I typically catch way more things than she does still.
You've been doing this for a long time.
Correct.
So you're an expert.
So, but part of the way I got there is just by comparing and reviewing this contract after this one, after this one. So these other people on this call can do the same thing.
Right. Okay, cool. Let's see what else we have. Daniel says the most common payers deny coverage for products like skin grafts, regardless of whether these products are covered by Medicare. Any advice on how to write those products into our contracts?
Well, certainly first, just ask. Don't be afraid of the no. You will be surprised how many times you can get those things added. But that brings up a great comment. My contracting team, my department is not set apart from our operations. So as operations is experiencing, hey, they don't pay for this, they don't pay for that, they feed that information back to us, and then we include that in our negotiation. One of the ways to get that included is to ask for 3 things. And you're going to have to give up on 1 and 2, but you get that one. If you got to give to get. And so incorporate additional asks, and maybe the one that's higher to the moon than that is the one they don't give you, but then you say, well, okay, you got to give me this one then.
Right.
So lots of different ways to go at it.
Okay, great. Okay, so Bob Burley, good friend of mine, he writes, note that it is usually illegal for an insurer backdoor negotiations by going to the hospital. They are an unregulated third party, and going to them breaches the confidentiality clause of your contract.
That is absolutely true. It still happens. Bob is absolutely correct. And that's certainly something to remind the hospital, particularly if you feel like that has been happening. So Bob, your point's great, but I can't tell you how many times I've had the distinct impression and very high belief that it's happened anyhow. So preparing them ahead of time, just so that they know what the what you're actually doing, and they're not caught off guard is still quite a good thing to do.
Okay. We're going to wrap up now because we're at the hour, but I just want to say Bob is going to be joining us at our next mastermind on April 9th. Please save the dates. And I want to just have you write down the next few dates for our masterminds: April 9th, May 9th, June 13th, July 9th. So for the next 4 months on the 9th, except for June on the 13th, we have the topics upcoming are benchmarking, reporting, productivity. We'll be covering billing company operations. We'll do an industry overview, how to get to the next level, building, motivating, and rewarding a winning team, and many, many more exciting ideas. There is a survey at the end of this call, so please respond to that. Ramesh wants to know if he can have a copy. We'll be giving out a copy of the slides.
Yeah, just reach out to me.
Okay, fine. We'll reach out, send an email directly to Tim and he'll give it to you. What is the ideal time to start contract negotiations? How many months before term?
Well, so you want to look at your contract and identify when it renews, because if it isn't renewing for 7 or 8 months, they're not going to give you the increase before that. But also because if you have to put a termination on the table and your termination clause is tied to renewal, so you have a 90-day termination clause and it's going to be tied to the renewal date, then you've got to get your termination 90 days before renewal, which means I have to start my negotiation 120, 150 days so that I can tell if I'm going to make the success. If I'm not, then I have to think about my termination and whether I'm going to use it or not by that 90th day. So that's when you're gonna back up your negotiation from the termination timing.
Got it. Okay. Thank you so much, everybody. If you have any additional questions, you could always email us or email Tim directly, and you will get a recording of this whole hour session. So check your emails, and there'll also be a link to sign up for the next one. We're so happy to have you. It's so great to see such a great group of motivated entrepreneurs. Thank you so much, and we'll see you next month. Join our Facebook community to continue to stay in touch. Bye, everybody.